Welcome to our podcast. My name is Dr. Xavier Mmono. I am the Medical Director of the Cheshire Clinic for Women's Health, otherwise known as MRCOG Health or the Laser Anesthetic Clinic. I am a consultant in obstetrics and gynecology, but also have a background and interest in medical law and in aesthetics. As previously mentioned, the aim of this podcast is to provide information for you on subjects that you will find interesting, for you to answer questions, and for me to provide the answers. And as I said, in some circumstances, you may have the answers and I may learn a lot from you. In today's podcast, I thought we should discuss an also common problem of what is clinically called abortion or miscarriage, and we will, towards the end of the podcast, deal with the subject of induced abortion, which of course is illegal in this country. Medicine is full of definitions, and some of them are quite archaic, but it is often a very good place to start when you address any subject. First of all, what is a miscarriage or an abortion? It is defined as an expulsion of a fetus from its mother before the age of viability. Viability is somewhat subjective. In the original definition, it spoke about 28 weeks, but with advancing technology, 24-week babies survive. And the definition has moved from 28 weeks to 24 weeks, and sometimes even to 20 weeks. If such a fetus does show a sign of life at birth, it is no longer seen as an abortion, but as a neonatal death, regardless of what its gestation was. These signs of life have legal consequences in that fetus that has just been delivered is assumed to be a live birth, and therefore has to be registered as any other death that occurs after birth. We will not deal any further with that in this podcast. Abortion can be spontaneous or it can be induced. It can be induced to save the mother's life, or more commonly nowadays in what is called a social abortion. The word has now been hijacked to mean just any other termination that is done for social reasons rather than for medical reasons. Spontaneous abortion is probably a lot more common than what statistics show, based on the fact that most pregnancies will be written off as a late period rather than the fact that conception had occurred in that particular cycle. Let me define a couple of terms related to spontaneous abortion. You will sometimes hear a doctor saying that you have a threatened miscarriage or a threatened abortion. This is when there's bleeding in early pregnancy, where the fetus remains viable, the neck of the womb or the cervical os remains closed, and usually there will be minimal abdominal cramps. As the term threatened suggests, the pregnancy is still viable and may very well progress to term. The next term is an inevitable abortion, where the pregnancy is still within the uterus and there may in fact still be a fetal heart, but the neck of the womb is open and there may have been heavy bleeding and sometimes accompanied by uterine contractions causing abdominal pain. Once again, as the term suggests, it is more likely than not that the pregnancy will be lost. The next definition is that of an incomplete abortion. In this case, some of the products are retained within uterus and some have been expelled. It is sometimes possible that the remainder of the products will deliver spontaneously and that an evacuation of the uterus may not be necessary. In a missed abortion, the pregnancy is retained within the uterus, quite often with minimal bleeding and sometimes without any uterine activity that will herald its spontaneous expulsion. There is also a term called a septic abortion, whereby the pregnancy has been infected and is often associated with outside interference. To terminate the pregnancy, and it's a leading cause of maternal death and morbidity in the developing world. Retained products can themselves get infected without any criminal intervention to terminate a pregnancy. Early pregnancy loss, painful as it is in fact a form of natural selection. There is a very high incidence of genetic abnormalities amongst pregnancies that are lost. And this is probably nature's way of making sure that abnormal babies are not carried to later pregnancy or in fact born alive. There is not enough time in this podcast to go into the causes of miscarriage or in fact discuss the management. Let me spend a few minutes talking about induced abortion. I've already stated that sometimes a pregnancy is terminated for medical reasons, usually either because the pregnancy itself is a threat to the mother or because the fetus may be grossly abnormal. There are also laws in many countries that allow for people to opt to end unended pregnancies for what is usually termed socio-economic reasons. The laws of Botswana do not allow this, but a significant proportion of our citizens cross the border to neighboring South Africa to have the procedure done, either medically or surgically. This type of abortion is illegal in South Africa. First legalized in 1967 in what was known as the 1967 Abortion Act. This was seen as a fairly liberal move, and checks and balances were put on statute in order to pacify the conservative majority at the time. One of the provisions was that the woman should be seen by two psychiatrists who would agree that she qualified to have a termination of pregnancy for non-medical reasons. The demand for the service was such that there was not enough willing psychiatrists to assess these women, and in the end the responsibility was delegated to any two doctors who were in agreement. This was often the general practitioner who would refer the patient to the hospital and the hospital doctor who would accept the patient for treatment. Amongst the provision of the Act was that a pregnancy can be terminated at any time if the risk to the mother's life was higher than the risks of terminating the pregnancy. Pregnancy places increased risk on the health of the mother, including even death. It is therefore obvious that if a safe termination were to be carried out before 12 weeks, it will be within the legal definition of the pregnancy, putting more risk on the life of the mother than were she not pregnant. With the advent of medical termination, where surgery and anesthesia are not involved, the attendant risk of termination became even much lower. It is, of course, infinitely safer not to get pregnant, but to rely on effective contraception. One of the provisions of the 1967 Act in the UK was that if a medical practitioner did not agree with termination of pregnancy, he should not impose his views on the patient, but should be prepared to refer them as a statutory right to another colleague. This is not a campaign to legalize abortion in Botswana, and this matter has been debated at length in the past and was opposed very strongly by, amongst others, the Catholic Church. I still recall bumper stickers on cars that said "Madiki Moto," referring to an aborted conceptus. We should, however, not turn a blind eye to the fact that those who can do. They either travel to South Africa or, in fact, travel as far as the UK to have the service safely and without any need to justify their actions. As usual, I will be more than happy to receive any constructive comments that there may be, and also to answer any questions that have come up during the course of the podcast. Thank you.